this is how you fill out your anesthesia workup sheet for junior surgery, or beyond that, clinics as well. So all of the patient info will go up here. So ideally you will have a sticker that you will place here. At a minimum, we need the patient, their name, species, and their medical record number. Then you will want to put the procedure that's being done, today's date, and the clinician for which you are doing the procedure for. In this case, it would be, for example, Dr. Hardy, Dr. Colopy, and then your name as the anesthetist. You'll put the attitude and temperament. So for example, our patient June, she is bright, alert, responsive. She's a little bit shy and nervous. Body condition score, and then the history. And this is history that will be pertinent to anesthesia and anything that should be noted in the medical record. For junior surgery, oftentimes we don't have an extensive history, so it might be just as easy as arrived at the shelter, received vaccines, and nothing else beyond that. Obviously, you'll put what is relevant for the specific case. Then we'll want to know if there's been any other anesthesia or sedation, and this becomes very important when working up a plan. Oftentimes, there's no known anesthesia that has been done, but if we have that information, we'll want to include it in or on our workup. We'll want to know if there's an IV catheter in place. And then if there was a previous anesthesia, we'll want to know the size of the endotracheal tube that they used. For the purposes of junior surgery, put down the size tubes that you'll want when you prepare your space. Then you'll put part of your physical exam findings, your temperature, respiration, heart rate, weight in kilograms, things like that. We'll always want a PCV and total protein, and then any other blood work that we have. Then you will put down anything that you find for your physical exam on their cardio status. So anything on auscultation that is worth noting. You can put no significant findings or within normal limits. So you can see here for cardio and respiratory, I have no significant findings. Or if there are no significant findings, you can also put a line here saying that there was nothing of note. Never leave something blank, because that just indicates to me that you have just not filled it out, as opposed to there is nothing significant. So either write that there's no significant findings, or leave a line in it, or of course write down anything that you find that is significant. Then you'll put any current meds that the patient is on, the medical surgical problem list. This would include, of course, for this, that they're in for an elective OHE. You could also put something in here like history of upper respiratory tract infection, possible pregnancy. These are the things that would go in this problem list. Then you'll want to list any possible anesthetic complications that you anticipate. And I will say that every case that we do, there are complications that we can anticipate. If nothing else, we can anticipate pain. Then you'll want to mark the ASA status that you believe your patient is prior to anesthesia. You'll pain score your patient. And then we'll mark whether we have client authorization and whether that client has elected CPR or elected for do not resuscitate. For the purposes of junior surgery, we almost always have client authorization from the shelter itself, and we'll go from there as far as the client authorization and then CPR. down in clinics, you will have specific forms for client authorization and CPR. Then we turn to the back of our record. And again, we repeat the patient's name, their species, breed, age, and sex, weight, and then we can lean body weight that patient as well. So if we believe the patient is overweight, we can put a lean body weight that we believe is more accurate for that patient. Then we'll list the pre-medications that we would like to use in our patient. For example, in junior surgery, you'll use acepromazine, hydromorphone, and ketamine in all of your cats. We'll give it IM. We have a dose range in milligrams per kilogram for that patient. From that, we can calculate out the anticipated dose based on our patient's weight. We have the concentration of the drug. Hydromorphone is varied. And for the purposes of junior surgery, I don't need you to put in a specific drug concentration because I often have to pull up from different concentrations. We then will put down the anticipated milligrams that we would like to give. So from this dose range, you will need to pick one dose that you want to give to your patient and then calculate the volume of that based on our drug concentration in milligrams per mil. So for example, acepromazine, I chose 0.1 milligram total dose at 2 mg per mil. That's 0.05 milliliters or cc's, and so on and so forth for the rest of the drugs. We'll do that for propofol as well. Then we can go down and pick the inhalant that we'll be using, isoflurane. And one of the things that will be helpful is to write down the MAC of isoflurane for the species of the animal that you are anesthetizing. Then you'll calculate out your fluid rate. The fluid rate that we'll be using is 5 milliliters per kilogram per hour. So based on our 3 kilogram cat, that works out to be 15 milliliters per hour. Then doing our math for a 60 drop set, meaning 60 drops per ml of liquid, I can calculate out that we're going to give a quarter of a drop per second. Well, I don't know about you, but I find that a quarter of a drop per second is very difficult to count when looking at a clock. So I'm more likely to say I'm going to be looking for 2.5 drops every 10 seconds. And I just do that to make it easier for myself when I'm calculating my fluid rate. We will not be doing constant rate infusions. You'll then want to put down that we're doing lidocaine topically on the arytenoids for intubation. We'll give Simdol at the body wall closure at a dose of 0.18 milligrams per kilogram. And Onsior as our NSAID at induction. So after we induce and get our patient stabilized, we'll give Onsior, and both of these will go sub-Q, and we can calculate out our drug volume. We'll want to calculate the total blood volume of our patient, and we'll calculate out all of our emergency drugs that we might need under anesthesia. This is a good practice to do with every patient that we anesthetize. You'll then decide whether you anticipate using a ventilator, which we won't in junior surgery. You'll calculate the tidal volume of your patient and the respiratory rate that you'll be looking for. Additionally, whether you'll need positive and expiratory pressure, and that's not anticipated with any of our patients. You'll also look at postoperative pain management. For the purposes of junior surgery, that's Symbidol and Onsior at the doses above. We will be recovering in the ward. And our monitoring plan, we'll want to figure that out for every patient. Down in clinics, this might change. But for the purposes of junior surgery, we'll do an SpO2, temp, and tidal CO2, and some form of blood pressure monitoring, whether that's a Doppler or an oscillometric non-invasive blood pressure. And we'll be placing a short-term IV catheter. After you complete your plan, you will need to have this approved by one of the anesthesiologists, who will go over the plan and put their signature here. And this then works kind of like a prescription form for the drugs that are going to be drawn up here. And that is it.